So now we're going to change gears a little bit and talk about, still talking about neurotrauma and traumatic brain injury, but get into some other aspects in managing these patients. So we have an 18-year-old who was at a graduation party who was struck in the head with a cue ball. He lost consciousness, and the family noted that he was shaking and thought he was cold, so they put him in a bathtub of warm water, and then the next morning they noticed that he hadn't woken up, and so they called EMS. So this is a true story. This did happen. When he arrived, his blood pressure was 210 over 110. His heart rate was 40. His temperature was 37 degrees. His GCS was 2T. His motor was 1. His eyes were 1, and he was intubated. He did not open his eyes, did not follow commands. His pupils were 3 on the left and 6 on the right. 3 on the left, 6 on the right, and both were non-reactive. He had no corneal, no cough, no gag, and no movement to stimulation. So this was his initial CAT scan. It shows an acute subdural hematoma on the left with brain compression and what we say is left-right midline shift. And so my first question is the patient brain dead? And the answer is no, because again we have to look for and find out, are there any other reasons that the person would have the exam that they have based on pharmacology, temperature, electrolyte abnormalities? Is there something else causing them to not be responsive? And so this patient was pharmacologically paralyzed. And then let's talk about his vital signs. So his blood pressure of 210 over 110 and a heart rate of 40. So what this is demonstrating is called the Cushing reflex. So as a person's intracranial pressure, that's ICP, goes up, the cerebral blood flow, CBF, that goes down, which results in cerebral ischemia that causes a sympathetic activation, causing vasoconstriction. That is trying to reduce the amount of blood going into the brain to try and keep that pressure lower. That increases cardiac output, which increases blood pressure, which then hits the baroreceptors, and then the person gets bradycardic. So it's a paradoxical physiologic response to elevated intracranial pressure that is a combination of hypertension, bradycardia, and agonal breathing. So a person who is wide awake and talking cannot have a Cushing response. This is a precursor to brain herniation. So uncal herniation, there's different areas where you can herniate. The one of example that we gave with this patient is that he had herniation of his uncus. It pushes over and pushes on the third nerve, which causes the inability for the pupil to constrict. So it disrupts the parasympathetic response to the pupil, and so the pupil is dilated with an non-competition of the sympathetic response. This person went for a craniotomy to evacuate the hematoma, and 2 years later is doing neurologically relatively well. He's at home, talking, interacts with his family. So again, very important to understand early whether that person is in fact not brain dead, so that you can make appropriate decisions based on their next steps in clinical care. So let's talk a little bit more about intracranial pressure. So we've got a 46-year-old male who presented after he was on a motorcycle versus cow. So he was a GCS of 6T, so his motor was 5, so that's localizing. He's not opening his eyes, and he's intubated. He does not open eyes, does not follow commands. His pupils are reactive. He has a corneal reflex. He has a cough and a gag, and he's moving all of his extremities spontaneously. So 6T, that's comatose. This is initial head CT that shows a right-sided right temporal contusion. There's a small subdural with some brain compression and a little bit of mass effect. hospital day 2. So if we see on hospital day 2 that the ventricular system is now collapsed, there's been effacement, is what we say, of the cisterns, the sulci of the brain are no longer visualized. So the patient was admitted to the ICU, an external ventricular drain was placed at the bedside, and the intracranial pressure was elevated to 30 millimeters of mercury. So what do we do next? So let's talk about the Monroe-Kelly doctrine. So the Monroe-Kelly doctrine is a little bit like the law of gravity for the brain. So inside the skull, there's venous blood, there's arterial blood, there's the brain tissue, and then there's cerebral spinal fluid. And so there's equilibrium, inflow and outflow are equal in the normal ICP. When a person has a mass inside their brain, that's got to push something out. So something has got to give, something has to flow outside of the brain. And it's either spinal fluid or blood. Because the skull is not going to expand, correct? In adults. Children is a little bit different, but in adults, the skull is a fixed structure, and so the more you put in it, the higher the pressure goes up. So if you have a mass, you've got to remove either the blood or the spinal fluid. And then as that mass increases, that pushes more and more blood or CSF out. And so when we place an external ventricular drain, then what we're doing is we're allowing that pressure to push spinal fluid out and give more space for the mass inside the brain. And this reduces the pressure. So treatment of elevated intracranial pressure. So the first step is sedation. Elevate the head of the bed. Make sure that they're not hypercarbic, that they're normocapnic, they're normothermic. Then we place an external ventricular drain, which allows for drainage of the spinal fluid outside of the ventricular system, and mannitol or hypertonic saline, which is an osmotic to draw the interstitial fluid into the blood flow system, and then the patient will then urinate out that extra fluid. So osmotic therapy works like this. So there's an osmotic gradient, and so that will draw fluid from the left over to the right. And then when we give those diuretics, then the patient urinates out that extra fluid. So just to give you a sense of a dog, Great Dane generates 0.4 gallons of urine in 24 seconds. A bison is 5.5 gallons of urine in 20 seconds. And then an African elephant gives you 42 gallons of urine in 22 seconds. So there's some keys to osmotic therapy. It's that the patient has to be hemodynamically stable. ABCs take priority, so airway, breathing, circulation. So you don't want to have someone who is hypotensive and bleeding and then give them a diuretic. And then lastly is surgical options, where we take the patient, and remember that Monroe-Kelly doctrine is the presumption that the brain is the skull is fixed and that there's no more space. Well, what we can do is we can take a patient to surgery. We can do a craniectomy, where we remove a large window of bone, and then we open the covering of the brain, called the dura, to give the brain space. And that's what we did for this individual. So we took him to surgery. We opened up a large cranial defect to give his brain room. And then you see here, after doing so, those cisterns, that ventricular system, that's the dark areas in the middle, have started to open. In that patient's now no longer having elevated intracranial pressure. So the keys of management of intracranial pressure, again, are sedation, elevation of head, drainage of cerebral spinal fluid to give the mass more space, that Monroe-Kelly doctrine, and then osmotic therapy, mannitol or hypertonic saline, and then also last resorts is a decompressive craniectomy to give the skull more space.